go ahead and move on to our next session, which now we will be beginning our great panel sessions where we're going to hear the physician perspective followed by the patient perspective, and then we'll be discussing those in between the sessions. So really excited to do this and really thrilled with how these turned out. So.
Well, thanks. And we're going to have two presentations in this section, one by Dr. Braden, who's actually the head of neurogastroenterology and motility at Mass General Hospital in Boston. He's going to provide an introduction on nausea and vomiting. And then we're going to have a patient perspective by Dr. Trisha Bundy.
Yes, absolutely. And Trisha is actually a member of our patient advisory committee, and she is fantastic. Her story is very, very enriching. So please, we hope you enjoy this.
Hi, my name is Brad Kuo. I'm a GI doctor at the Center for Neurointestinal Health, the GI unit at Massachusetts General Hospital, Harvard Medical School in Boston. And today I'll be talking to you about nausea and vomiting with some insights into treatments. As a definition of nausea, people often describe it as an unpleasant, painless sensation that frequently, but not always, occurs before vomiting. Epigastric discomfort with the urge to vomit or changes in the autonomic nervous system, a nervous system that controls various organs in our body that can be characterized as dominated by heavy sympathetic load, which means nerve endings which control the fight or flight symptoms. Now, evolutionarily, nausea is thought to be this early warning body system, but it's evolved to occur frequently when we actually have non-acutely life-threatening events. And nausea, interestingly, is not pain. People can tell the difference between that, but it is frequently associated with that. So you can have nausea without pain and vice versa. And as we all know, nausea frequently occurs after motion sickness. So
Hello,
it's interesting,
and welcome back.
We often associate nausea and vomiting together, but they actually are distinct events. So vomiting does not require you to be fully aware. It's a reflex that can happen, whereas nausea requires you to be consciously aware to know what's going on around you to give you nausea. So vomiting is a reflex, and nausea requires that conscious perception. A lot of work has been done with vomiting because there's actually animal models to understand that, and so they have mapped out a lot of the circuits in the brain, which are actually not in the top part of the brain, but more in the old part of the brain that is hardwired with reflexes. Whereas nausea actually involves the nerve endings in the body as well as in the top portion of the brain where there's conscious perception and thinking occurring. There are neurotransmitters, which are chemicals that mediate the vomiting, and that's well known in vomiting, but completely not understood in nausea. And this is ultimately because there are animal models for vomiting, but actually because it requires conscious perception, there are no real animal models for nausea. And so only humans have been a way that you can understand what's going on with nausea in people. Ultimately, that results in that there are multiple medications called antiemetics that are good for vomiting, but they actually don't have as great efficacy in nausea. So this slide sort of shows you that there are different inputs from the heart and in the stomach. These feed through various nerves called cranial nerves, such as the vagus nerve, and as well as sympathetic and parasympathetic activity that eventually hit the vomiting center in the old part of the brain. And these are partly gated by things called the chemoreceptor trigger zone. And these are some of the hormones and neurotransmitters that are involved in that sort of stuff. And these filter through the parts of the old brain and eventually reach the cortex, the thinking part of the brain, where we can establish feelings about it, such as discomfort, whether there's anxiety associated with it, other sorts of things mediated by these parts of the brain. As we all know, there's the inner ear that if you get motion sickness or you get spin yourself around in rapid circles, that can also cause nausea and motion sickness, and that feeds from the inner ear to this portion of the reflexive area of the old part of the brain. Eventually, these things all go through an area called the nucleus tractus solitarius, which is the main gateway relay center to the brain for all these types of signals. Now, we did some interesting work to try to understand what's going on with nausea, because again, there are no great animal models, and so we were trying to figure out what parts of the brain are actually involved when you get nausea in human beings. And we were lucky to be the first to report taking human people that are motion sickness prone, subjecting them to this visual stimuli of alternating black and white stripes, sort of like what you would see in an amusement park ride, but sitting inside an MRI scanner. And as we started to make them nauseous inside the MRI scanner, not to the point that they were going to puke or vomit, we started to see areas of the brain light up. And these areas, such as the amygdala, putamen, and dorsal pons, and locus coeruleus, these are sort of relay areas that are now starting to light up when you're starting to feel nausea coming on. And these are related to awareness centers in the brain, or almost the fight or flight areas in the brain. So it's telling you something is going on that's not right. Then when you actually do get nausea, other areas light up, such as the ACC, the anterior cingulate cortex, the insula, and the medial insula. And these are areas that start processing the sensation of nausea and telling you that, boy, this does not feel good. I think this is a bad sensation, and I might be feeling some extreme discomfort. And interestingly enough, these are the same areas that light up when you have pain. And so that even though nausea is not pain, we're starting to see this sort of circuitry that occurs in the brain when you get nausea that completely overlap with what is activated in the brain when a person has pain. Two distinct symptoms, but similar overlap of brain activity. This is important meaning, because ultimately this might mean that some of the treatments that we have for nausea may not be just purely based on trying to decrease the vomiting, but maybe have overlap with the same medications that we might use for pain to change how the brain perceives the nausea. Because remember, nausea can only happen if you're awake and can perceive that sensation. Another interesting thing that we did was we took people who had chronic nausea, and we noticed over time, if you have chronic nausea, there are literally changes in the way your brain is wired after chronic exposure to nausea. And that also happens with chronic pain. There are changes that occur in your brain to the wiring that occurs when you have chronic pain. And in this case, this particular wiring tract between the front part of the brain, the anterior insula, and then the visual part of the area is altered in terms of some areas of the circuits compared to people that are less susceptible to motion sickness. So ultimately, we have here this pathwork that we've sort of mapped out in the brain that overlaps the pathways that are activated when you have a pain, so that nausea activates similar pathways that pain activates in the brain. And this can occur over time in chronic people, and that these give also feedback eventually to the vagus nerve and the sympathetic and parasympathetic system to different things that you can see in sweating, increased heart rate, stomach activation or function. Now, there are many ways that you can get nausea into the body. You can get it from the periphery, below the brain. There can be mechanical or chemical irritants, like if you eat something bad or something's going on in your body that's not right, that can feed into the brainstem, giving you nausea. There are blood agents that, if you take a medication, that may give you nausea, or chemotherapy. Motion sickness through the inner ear can cause nausea, and that feeds into this brainstem, the old part of the brain that eventually processes and relays it to the cerebral cortex, the thinking part of the brain, where with the nausea you can layer things like pain, emotion, and such. So as a result, we have a better understanding of nausea now in human beings, where there's a central nervous system part of the brain that figures out where the nausea, what the nausea sensation is, and attaches to it emotional response to that. In addition, we have nerve endings that course through the body, through the gut, and through other nerve endings such as the heart and lungs, and also the body bloodstream, which tells what's going on with the body. And if there's not something right, it will feed that signal eventually through this peripheral nervous system to the brain to tell you something's going on. Now, these can be modified through the sympathetic and parasympathetic system. This is an autonomic nervous system that sort of steps on the gas or slows things down in the body in response to something that may be going on. But this all leads to the idea that when patients have nausea, it's due to them crossing a certain threshold, where above that threshold, they have nausea, and below it, they do not. But that threshold can be dynamic. And so that in some patients, that threshold can be lower, making them more nauseous. In other people who don't get motion sickness at all, that threshold can be very high. And so ultimately, when we think about how to treat nausea, we can think about how are we going to change the dynamic threshold, either through medications or other sorts of things, to change how we think about that nausogenic stimulus and how the body ultimately will respond to that. And also from what we've learned, the nausea circuitries are similar to the pain circuitries within the brain. And so that gives us further ideas about how we can treat people who have chronic nausea. Now, when we talk about nausea, we oftentimes look at the evaluation. We ask a lot of things about the history. What happened? Did you have anything that occurred in your childhood that may give you increased nausea? A history of eating disorders? Do you get nausea all the time or early in the morning, or does it wake you up from sleep? How well do you sleep? And oftentimes people get nauseous when they have meals or when even with the smell of food. So all these can trigger nausea and may have relationships with pain, emotion, or memory. Sometimes sadness can give us nausea. Oftentimes we ask questions about medications because a lot of different medications can give nausea or vomiting. One of the common ones, an antibiotic called erythromycin, actually stimulates the gut, and that can cause nausea. And oftentimes interactions with different drugs, polypharmacy can give nausea. And certainly there are interesting drugs, narcotics and marijuana that can either make nausea worse or marijuana can actually make nausea better. Now, the doctors, because nausea can be caused from so many different things, the doctors usually do a broad search to make sure there's not anything life-threatening, such as checking your blood salts with electrolytes and checking to see about diabetes, thyroid disease, and other sorts of things. Then we try to check the gut with x-rays and with endoscopy to make sure there's no blockage and make sure there's nothing going on in the brain. One of the areas that will interpret the nausea with a CT scan if it's severe or if there's changes or damage to the nerve endings that relay all the signals from the body up to the brain. We may also check the gut motility because sometimes an abnormality in gut motility may cause nausea or indicate there's damage to the nerve endings in the gut, which may precipitate nausea. And certainly things like anxiety and depression can make nausea worse. So this list is a few things that we'd like to rule out for chronic nausea, things like blockage of the guts, irritation or inflammation that can be caused by infection or different types of medications or other sorts of inflammation or other body structures. Certainly certain medications such as chemotherapy can cause nausea or impaired gut motility, which means how stuff moves from one end to the other in the gut. Because if the gut has problems with moving stuff, the nerve endings can be dysfunctional, which can lead to sensory problems such as nausea. And ultimately, there is a criteria for nausea called functional idiopathic nausea. That's when there's bothersome nausea at least several times a week. That's associated with vomiting. It has to occur without any abnormalities, structural by endoscopy. It has to be for 3 months, for at least 6 months. And that is really a person that has chronic nausea all the time, and it can overlap with a number of other gut diagnoses. Now, the main classes for treating nausea and vomiting are the antiemetics, drugs that actually reduce vomiting, but to a lesser extent, nausea. And so these are plentiful. There's a lot of different drugs out there, but interestingly enough, they've been well targeted towards decreasing vomiting, but have less been successful for nausea. Prokinetic agents, medications that accelerate gastric emptying, might decrease nausea a little bit, but if you push the gut too hard, it may actually induce nausea. And then this concept of sensory modulators. Drugs, now that we understand that there's activation of circuits within the brain that are similar to pain, can we change the threshold within the brain and maybe even within the body of what the threshold will be for stimulus to induce nausea. And maybe we could increase that threshold in patients where it may have been pushed artificially low, that may have given patients more nauseous symptoms. So some of these medications are listed here. They're fairly common, such as meclizine, promethazine. There are scopolamine patches and other things to push the gut and change some of the nerve endings. Common one is serotonin modulation, ondansetron, and neurokinin, such as apripitant, and certainly the marijuana-like medications called cannabinoids. Benzodiazepines help with nausea and with vomiting, because by decreasing the awareness of the brain with a benzodiazepine, you can actually decrease the nausea. But a lot of these medications work well with vomiting, but don't work well with nausea. And oftentimes, if you sedate the patient, make them less aware, make them go to sleep, it will reduce the nausea and may even reduce the vomiting. So really, what we learned from some of the brain work is that patients with chronic nausea may have changes to their brain similar to people who have chronic pain. And maybe we can use medications to change that process, such as tricyclic antidepressants. These are medications that are chronically used for pain, but they change the way the brain interprets signals, and as well as changing the way the gut interprets signals. And maybe that can be used to decrease nausea as well. And there are different types of agents, tricyclic antidepressants, anti-epileptic agents such as gabapentin and topiramate, which has less GI side effects, and maybe even some antipsychotics which affect dopamine and serotonin, like olanzapine, which has also been used for anxiety and depression. Now, nausea obviously affects one's appetite, and so stimulation of meals or meal composition can cause fears of eating and ultimately loss of weight. And so things such as cognitive behavioral therapy can be employed, and we have to be on the lookout for this issue. If nausea causes fear of eating, it can lead to significant behavioral changes and an entity called avoidant restrictive feeding intake disorder, ARFID. Also, we know there's this relationship between food and emotion and smell and memory. And ginger has ways of sort of relaxing the gut that can help with nausea. So there's actually a whole host of alternative treatments. Acupuncture, by pressing on your wrist, there is an acupuncture point that may decrease nausea and vomiting. And along those lines, there may be nerve stimulators that affect the nerve ending, the vagus nerve, which mediates a lot of the gut sensations, upper gut sensations in nausea and vomiting. I mentioned cognitive behavioral therapy, mindful meditation, and hypnosis are ways that are altering the brain in terms of trying to control nausea symptoms by decreasing that or changing that dynamic threshold for nausea. So in summary, nausea vomiting may be elicited by stimulation of several sites in the brain as well as in the body nervous system. There's many different things that can cause chronic symptoms of nausea and vomiting, including gut motor and sensory disorder issues. Diagnostic testing, such as endoscopy, is important, but also history is very important. And there are a number of medications which are good for good for vomiting, such as antiemetics and prokinetics. But I think in evolving areas, this change of trying to improve the threshold of nausea, and that can be done with neuromodulators. Thank you very much.
Hello, my name is Trisha Bundy, and I'm here to share a little bit about my patient journey with gastroparesis. But before I share, I did want to thank IFFGD for all that they're doing to help raise awareness and increase research for gastroparesis and other GI disorders. I also want you to remember that this is my personal journey. Other people's experiences, reasons for gastroparesis, symptoms, treatments, outcomes will all vary depending on the person. So prior to becoming ill, I was a semi-normal person. I say semi-normal because I don't know that anybody is completely normal. But I was a scholar athlete in high school, went to college, married my husband as soon as I got out of college, started my dream career, which was teaching elementary students. And then, of course, I was an active teacher, but then became a very active mother as well as my children came along. However, in February of 2013, everything changed dramatically and unexpectedly. I went to bed that evening, just a couple days past my 35th birthday, after having a normal meal with my family and getting my kids ready for bed. I say normal meal because I haven't been able to have a normal meal since then, and it's been over 8.5 years now. I went to bed that evening, woke up around 1 o'clock in the morning, severely nauseated, cold sweats, vomiting, and didn't know what was going on. Severe, excruciating abdominal pain. This went on for a few days, and at first I thought, oh, okay, I caught the bug that's going around at the school or that my kids might have been carrying. But as I didn't get better, I started seeking out help with my doctor. My family doctor at first thought, okay, well, maybe this is diverticulitis. Or then when the pain continued and severity increased after trying to eat, then, oh, well, it might be appendicitis. You might need to go to the ER. So I was going back and forth with him. And then later in the month, I found myself at the ER numerous times in my local ER getting fluids for my hydration because I was unable to urinate anymore, and got to the point where I eventually became impacted, which was awful in itself. But then you add the fact that the doctors and nurses, some of them were blaming me in a way, saying that, hey, it's my fault that I wasn't getting enough fluids in. There's a way I could have fixed that, not realizing or taking in to affect how hard I really was trying and just unable to keep anything at all down. So that's when my disbelief and search for medical care began. I kept seeing my doctor for a while, and then after a month of not getting anywhere with my local ER or local doctors, I started looking outside of my town. And I was driving 45 minutes one way to go see a GI in a nearby city, where he ran numerous tests and labs, colonoscopy, endoscopy, having gone up literally all the way to the doctor's office to prepare for this test, which led to no answers again. Eventually, he threw up his hands, wasn't sure what to do, so he sent me to my gynecologist, who ran tests to see if it was anything maybe female. And once again, there were no answers, but he thought it was very kind to remind me of how losing weight was looking good on me. Of course, that's not what I wanted to hear when losing weight was the fact of not being able to keep anything down, and I was feeling absolutely awful day in and day out. I was also sent to a urologist who searched and did a cystoscopy looking for possible kidney stones. Of course, that came back negative as well. Then he was ready to send me to get a laparoscopic diagnostic laparoscopy, but that never came, as I ended up being hospitalized before we ever got to that point. As you might guess, this left me feeling very lost, misunderstood, disbelieved. I was trying everything on my end, but no matter what I did, I just kept getting worse, getting nowhere, and kind of felt like I was being tossed around. I was struggling to keep up with my responsibilities as a mother, wife, and teacher. Finally, months later, after continuing and missing tons of work, not being able to participate in the life of my kids, missing out on their school events and their ball games, my family had had enough. I was trying to get ready. I was getting up earlier in the mornings because I knew I was going to have vomiting to deal with. So one morning, getting ready for work, after spending an hour or so vomiting after trying to drink a little something just to give me some nourishment to get through the day with my students, my husband said, "You're not going to work." Instead, he took me an hour and a half to a university hospital where my family met us there. And when I was there, they gave me fluids because I was definitely dehydrated. And then they were ready to discharge me, stating that, hey, it might be just stress. Well, we knew that that was not the case. I mean, I was stressed, of course. I couldn't keep anything down. I couldn't be a mother like I wanted. I couldn't be the teacher that I wanted. But that was not the cause of all this. However, my family urged him to rethink it. He had me try to eat a cracker and a little bit of juice, and I was unable to hold that down as well. So after going through the heaving and vomiting that resulted, he finally decided that he would admit me. that's when things started to turn around as far as finding some medical help to at least that I could depend on. I had an absolutely wonderful hospitalist. He spent the week with me trying to figure out what was going on, to find some kind of treatment. We tried multiple medications. One of them at the end of the week was one I had been warned of at the beginning of the week from him, which was Raglan. My body did not do well with that. But we went home and I spent a week trying to get by on just a liquid diet, which was literally sipping Gatorade throughout the day in small sips. However, at the end of the week, that was a no-go. I was not able to keep enough down. I was not going to the bathroom, and I had to be readmitted, where they decided that a feeding tube would be the next step for me. The feeding tube gave me a chance to be able to vent my stomach and feed into my intestines. This was not an easy decision. I was very confused going into it because there was no one I knew that had feeding tubes, and nothing online that I could find about it or about gastroparesis. It took a while, but we finally figured out that my rate would be around 35 to 45. And here, over 8 years later, I'm still in that range, and multiple tries with different formulas. My GI care since then has been with that same system, even though my GI had changed. I have an excellent one now that I definitely depend and trust. Some of the medical tests that I've been through, you can see would be listed here. A lot of the common ones that you're probably familiar with. The strangest one was probably the defecography. If you know anything about digestive illnesses and about the diagnostic test for them, they are not fun. They seem to increase your symptoms and make you feel a lot worse, at least short term, while trying to figure out, hey, what could be the cause of treatment. As you can see, I couldn't handle a few ounces of liquid, and in that top picture, I had to get down that whole bottle. In the bottom right picture, you can see that was when I got down to my lowest weight, was on a feeding tube then, as well as getting IV hydration at home. But my weight kept plummeting because I could not get any nutrition in. Medical surgeries. In 2013, I had a GJ feeding tube placed. I still use that and depend on that for nutrition. Back and forth for pelvic sessions multiple times a week, all with, for a few months, all within about an hour and a half drive. Dilations for my esophagus that did not want to relax. Had gallbladder removal due to the amount of weight loss and the speed, how fast it occurred, and not in a healthy fashion. 2016, had my colon removed and an ileostomy placed. One of the toughest decisions I've made, but definitely one I do not regret. Picks and ports were tried for hydration. But if you know anything about picks and ports, you carry the risk of infections. And some reason or another, my body seemed to continue to get infections over those 4 years. So now I get peripherals when needed for outpatient fluids. Iron infusions for being anemic now, iron deficient anemic, and hospital visits and inpatient stays became normal for me for the first numerous years. In fact, this past year was the first year I made it without an actual hospitalization. Most of the symptoms I've already discussed. One that I didn't mention was I have a lot of like the muscle pain, probably from the lack of nutrition that I need, the bloating, the mental fog is very bad. And you can see some of my diagnoses, one being that the gastroparesis is idiopathic, meaning we don't know a cause for it, but it is possible there could have been a post-bowel part to it. And then you can see in the pictures, the heating pad, which is about the only thing that works for regular pain relief, how it is sitting at tables while everybody else is eating, and holidays are very similar, and the difference of the food. Nausea treatment. There, you can see nausea medicines as well as other medicines are a lot of trial and error. And a lot of these might have worked for a little while. Some did not work at all. There were a couple that actually made me feel worse, but that doesn't mean that it won't work for others. A lot of times what works for one person does not work the same for another person. And I also listed a few over-the-counter type things. The most interesting one that actually does help for me is that smelling the alcohol pads when I get to the point of heaving. That kind of helps calm it down. I don't know why. And then last, the self-awareness and acceptance. Mental health can definitely be impacted when you are living with a chronic illness. It's not something that is expected, but when your life is flipped upside down and you have to give up a lot of things that you were doing, when you have to resign from a career that you loved, you miss out on things with your family, they go on vacations without you, it starts to wear you down, not to mention the looks and thoughts that you receive from other people and doctors. But coming to the realization that, hey, it's okay if can't do what I used to do. I have to be able to accept my limitations, whether that means my feeding tube, enjoying small different activities with my family, even riding a scooter to be able to participate. That's okay. And then giving myself the grace when I can't, and then continuing to keep my faith and trust in God that I will survive the bad days just like I have already, that eventually there will be better days ahead. Thank you.
Hello and welcome back. We hope you enjoyed that session with Dr. Brad Quo and Trisha Bundy on nausea and vomiting. We have some discussion points here, and with me today are Dr. Bill Che from the University of Michigan and Dr. Lynn Chang from UCLA. I am Cecile Rooker, the President and Executive Director for IFFGD. So I want to start with Trisha's story because that was very moving for me. And she talked about waking up one morning with these severe nausea and vomiting episodes. How common is that with gastroparesis? How can you see that in your patients? Is that normal for someone with gastroparesis?
It's unusual. I mean, the most common causes of gastroparesis are usually tied to chronic diseases like diabetes, for example. But we're increasingly learning that an important cause for gastroparesis are acute infections. Now, this story is not typical of that, but it might provide an explanation. For example, if there was some exposure to a pathogen, a bacteria, a virus, a parasite, that can actually, the vast majority of the time, the symptoms will quickly resolve. People will develop nausea, vomiting, abdominal pain, diarrhea that goes away within a period of 24, 48, maybe 72 hours. But what we're learning is that somewhere between 7 and 15% of individuals with an acute infection will go on to develop more chronic symptoms. Now, I don't know if that's the explanation for a case like this, but it's one of the only things that I can think of that might provide an explanation.
Wow. And she also ended up with nutritional support on a feeding tube. And how common is that for people with gastroparesis? Do you see that happening a lot in your practice of having to move them into some nutritional support?
Yeah, it's less common. You know, of course, we don't have great treatments for gastroparesis. And, you know, we heard from Dr. Camilleri, fortunately, there's a lot more treatments that are being developed for that. But currently, we don't really have that much. And so it's a lot of symptomatic management. But usually you have to think about the patient's nutritional status. And when it's very severe and they can't keep up a good nutritional status, sometimes they will require a feeding tube. If they can eat still orally, you want to do that and maintain that. But this is obviously much more of a severe situation, but her overall health is really important.
Absolutely. So obviously with Trisha, she woke up, she was violently ill, and she went to see her healthcare provider, which is, you know, obviously great course of action for her. But what about others? Maybe with a less dramatic case, maybe a milder case of gastroparesis, or someone who has nausea and vomiting. At what point should they consider going to see their healthcare provider?
You know, occasionally people will get food poisoning or a traveler's illness that can cause some vomiting. And certainly if somebody has a clearly identifiable source for the symptoms, waiting a day or even several days is perfectly fine. But vomiting is actually a special symptom. It's what we call a warning sign or alarm feature. And when vomiting extends certainly beyond probably 5 to 7 days, it's definitely time to go see your doctor. you'll want to get some testing done to make sure that your body chemistry is remaining intact. You know, you can imagine that if you're vomiting for days on end, that can easily mess with varying levels of chemicals like sodium, potassium, chloride, et cetera. And that can become dangerous if it becomes severely out of whack. In addition to that, doing an endoscopy is also going to be important for an individual that has persistent vomiting to make sure there's not a structural explanation or something that you can identify that might allow you to choose a more precise way to treat the patient in hand. So a day or two with a clearly identifiable source, stay at home, drink lots of fluids as much as you can tolerate, and give it a little time. But really, more than 5 to 7 days, you really need to go in and see your doctor.
Okay. I think the other important point to make here, although it's a complex discussion, is really differentiating of whether or not the delayed emptying of the stomach is really truly the cause of the symptoms. If it's severely delayed, it does correlate with having more severe nausea and then having vomiting. But we do see patients with functional dyspepsia where they have this upper gut discomfort, burning or pain, and they may, about 25–30% may have very mild delay in emptying. Nausea is not that predominant of a cause. And in those situations, really speeding up the gastric emptying, the stomach emptying may not be the treatment that's going to improve their symptoms, because it's not usually associated with symptoms. So that's something to think about and differentiate, but I know that's a longer discussion.
Right, absolutely. And one you should definitely be having with your healthcare provider. Like Bill said, you know, vomiting is not normal. And so therefore, if you don't know why this is happening to you, make sure that you go see your healthcare provider to find out why that might be happening. So this was a great introduction to nausea and vomiting by Dr. Brad Clough, and a wonderful patient story from Trisha Bundy.